Thank you. Happy birthday, and it's a great pleasure to be invited to speak to you all today. Before I start, there are a couple of health warnings. First one is, I think Ian described those of us who are speaking as experts, and you've got to be very careful. My best and most favorite description of what an expert is a person who keeps making the same old mistakes but with ever-increasing confidence. So you've got to be careful how you interpret that. And the second is that some of my slides will look bewildering. They are really there for an aid memoir for me because there'll be some data on them that will be difficult for you to assimilate. Don't spend your time trying to work out what's on those slides. There will be some take-home messages on them, and I'll be talking through them, as it were. So listen, don't worry if the slide comes up and looks, terribly complicated. So let's get on. I'm here to talk about what may be out there in the future in terms of treating pulmonary hypertension. And I think a very good place to start is the value of remembering the journey we've embarked upon. We've heard a little bit about that. David touched upon that, and I'll just say a little bit more about that. It also gives us the opportunity to know that going forward, sometimes you don't necessarily need new therapies. Reflecting on what we already have and maybe using them in a slightly different way is potentially an option. And finally, there's been quite a common theme here uniting us all, you, the patients and carers, and we, those physician scientists who are trying to improve outlook and quality of life for patients with pulmonary hypertension, to recognize that together there's a great value in supporting both basic, translational, that means drug discovery into, or other forms of discovery to deliver healthcare, and of course clinical science to develop newer approaches to therapy. Well, I talked about the journey, but actually it seems a bit more like an odyssey. There's a slight difference because an odyssey, old Norse name, really describes a wandering or voyage marked by many changes of fortune, and I think we've all recognized that. Also, there's an intellectual or spiritual wandering or quest, and I think that also aptly describes where we've come over the last 15 years in pulmonary hypertension. Pulmonary hypertension, as we've heard, is a disease that very much at the very beginning was recognized that vasoconstriction, smooth muscle contraction of the blood vessels that supply blood to the lung to pick up oxygen, those constrict. And most of the treatment options were really described as vasodilators. They overcame that constriction to allow blood to flow more freely to the lungs, as David explained. But over the years, we've recognized that partially due to that vasoconstriction and also due to other mechanisms working in the airway, in the blood vessel wall, that there is a proliferation, a change in the structure of the blood vessel to the lung, such that there are changes there that won't be overcome simply by vasodilators. And so the treatment paradigm has moved from drugs that principally dilate blood vessels to include drugs that will alter the structure of the blood vessels, to change those changes that cause narrowing of the blood vessels through scarring and so forth, through an increase in smooth muscle in the walls of the blood vessels, and treatment geared towards, perhaps in the longer term, bringing out improvements in exercise capability and all the other things that you want to get out of a treatment for the disease you have. And we'll touch upon that. There are, at the moment, and over the last many years, a whole range of therapies that have been introduced for pulmonary hypertension, and you'll recognize these, bosentan and ambrisentan, the ERAs. Recently, we have macitentan added, tadalafil and sildenafil, We've recently had riociguat, not quite the same class of drug as tadalafil or sildenafil, but works on the same pathway. And then few of you will be requiring intravenous prostanoid therapies. And until now, the challenge of the prostacyclin therapies has been the difficulties in actually getting that treatment into patients. Only either via an inhaled route, which is tricky and awkward sometimes, or the intravenous route with all its problems. But you'll be aware, no doubt, and some of you will have taken part in clinical trials. There's an oral prostacyclin therapy, and we're working very hard at the moment with NHS England to ensure that in certainly May, I think, next year, we will have an oral effective prostacyclin drug on offer for patients, and that will clearly be something in the immediate future that is likely to be of benefit. So if we look from 1995 over to 2015, I would say that actually the community that's interested in developing pulmonary hypertension therapies, and that includes industry, the pharmaceutical industry, often criticized as simply profiteers. Actually not the case. Working with academics, drug discovery, huge billions of money invested in often a very risky potential, may not get a drug that's going to work, and yet it's cost billions of pounds to get that drug onto and into man. The pharmaceutical industry, the clinician or physician scientists, and the basic researchers, and you, the patients, through enrolling in clinical trials, have allowed a huge development in drugs. And actually in the specialty of respiratory medicine, there's no other disease group, if you like, where there have been so many new therapies brought in over that time. So we can, if you like, spend a small period of reflection to bask in the fact that we have been able to develop so many drugs that are of benefit to you. But of course, we recognize we're not there yet. The other thing that I think is very important is that, as Ian said at the beginning, we've recognized that it's not just drugs that are introduced that this disease is about. It's about the holistic and general care that needs to be thought of, both for patients and the families that are affected by this disease. And we've been aided, I think, over the years that this is an international effort. It's not just in the UK that this disease is a problem, as you know. And the world, if you like, is working pretty well together in terms of producing guidelines, and in one country develops something like exercise programs, and Germany have been particularly good in that area. We're starting to wake up and recognize good practice elsewhere. And it's through these world meetings that you see here that we're spreading the word. So what's new? And I mentioned early on that just looking at old drugs and how we might use them better. And there is some emerging data from the French group that to actually combine in a patient who perhaps presents quite poorly with severe pulmonary hypertension, rather than giving sequential add-on therapy, using all three classes of drug that I described up front, perhaps only for a few months initially to get control of the disease, might be better than seeing what the effect is on one. I think it's very early days yet, and I'm not saying using 3 drugs up front is the answer. It certainly isn't. But there have been, on this slide, some pretty good data showing significant improvements in the right heart catheter studies that are done acutely, and also pretty rapid increases in 6-minute walk distance that you can see, and functional class over something like a 6-month period. So I think this may not be the answer, but it does tell us that thinking of the way we perhaps combine drugs, maybe we should be thinking in terms of treating patients with 3 or 4 drugs right at the beginning, and then after 3 months, if there's a good response, starting to reduce drugs, because every time you add a drug together, there are potential additional side effects. We all recognize that. But I can see that over the next 5 years or so, we will be carrying out much bigger, proper control studies and trials to see whether we can use what we've got in a better and more effective way for patients. I mentioned selexipag very quickly. This is the oral prostacyclin therapy. There's a study that has reported and has been presented, but is not yet in the public arena in terms of a journal that has the study reported in it. But you can be pleased to see that the endpoint in this study, which was a mixture of morbidity, in other words, how sick, was the disease progressing or not in the patient, was significantly improved over placebo. And this was positive in terms of whether patients were either naive to any treatment on one therapy, an ERA or a PDE5, or a combination of those two. So this looks like it might potentially be a drug for those patients who are already on dual therapy and not doing quite as well as they would like, and not really wanting or able to manage the continuous intravenous pump. I think it's early days, and we're going to have to think about where a drug like this may fit into our armamentarium, but that is certainly one area, because that's a group of patients, I think, at the moment that kind of struggle on, not getting much better, not getting much worse, and we want to try and improve quality of life or health-related quality of life for that group. Iron. Well, iron's been around. It's an important part of us. We've known about the values of iron, and actually we've known about the value of iron in terms of the pulmonary vasculature, but we perhaps hadn't recognized until relatively recently that iron deficiency was an issue for many patients with pulmonary hypertension. And there's a trial particularly led by the Hammersmith group, I think the Sheffield group also, so patients from those may well be in this study, where iron is being given to patients with pulmonary hypertension to see if correcting any iron deficiency or loading with iron actually improves the situation. A novel use of a drug, iron. It's an elemental product that's in everything we eat, for example, but knowledge bringing forward the idea that an old drug, an old supplement, might have a role in treating pulmonary hypertension. Obviously, the ultimate aim of everybody working in drug discovery is to look for a cure, and we're not there yet. And I'm not going to stand here and promise we're going to be there in 5 years, but what I can tell you is there's a hell of a lot of exciting work going on, developing therapies that are not yet, some of them are just starting to go into man, as it were. In classical drug discovery, there's a whole journey of around often 10 years before the drug, a molecule that looks promising, actually turns out as a licensed treatment. And I think the future is good in this viewpoint. But I would remind us that Isaac Newton, his words back in the 17th and early 18th century, the challenge facing us is still here in pulmonary hypertension, because what we still know and understand is a drop. What we don't know is an ocean. And some of you may think money going into basic science, understanding disease, why are we spending so much money on that rather than perhaps research that's much more obviously delivering healthcare needs? And the answer is, the more we understand about what drives a disease, the more targets we'll find for therapies, and the new therapies will come through and ultimately deliver better health care for patients. So what do we know about pulmonary hypertension? What's the state of knowledge regarding mechanisms that cause pulmonary hypertension? Well, we know there are some risk factors. We know now that there's quite a significant genetic predisposition. We know that there are two cells that function very differently in pulmonary hypertension. In the blood vessels, the endothelial cells, those lining vessels next to the blood, and the smooth muscle that wrap around as a sort of middle core of the arterial wall. And we also now recognize that inflammation is a very, almost certainly, important additional factor that leads to that pulmonary vascular remodeling, that scarring, as well as the vasoconstriction that is the cause of all pulmonary arterial hypertension, irrespective of whether it's congenital heart disease or idiopathic. Clearly, heritable pulmonary hypertension has a more significant and obvious genetic predisposition. But the interesting thing is that the genetic side of things, the studies have now shown that the protein, that the changed gene that is responsible for heritable pulmonary hypertension, that protein that acts as a receptor on the cell, so this is a little signaling receptor, is downregulated even in patients who haven't got a primary abnormality of the gene. So the genetic research has thrown up the protein receptor abnormality on the cell, which actually is much more common in all forms of pulmonary hypertension and is therefore a potential target. Now, why is this important? Well, this is one of the most staggering experiments and results that we've seen, I think, in medicine, in respiratory medicine, for 25 years. Cystic fibrosis, many of you will have heard it, is a genetic disorder. It's the most common genetic disorder. It's due to a faulty gene. It's a gene that codes, again, for a receptor called CFTR on cells lining the airways of the lung. And one of the changed proteins, the way in which the protein is, means that that receptor is not in the right place on the cell. But it's present in the cell, it just isn't in the right place. So it can't signal properly. And basic research has shown that a drug can actually mobilize and move that receptor to the right place and increase its function so that it starts to work again. And so for a small subset of patients with cystic fibrosis, where the precise genetic change and that little protein receptor has been corrected, fantastic improvements in lung function, completely revolutionary, amazingly good results. And this must be encouraging for PAH, because we know a lot now about the genetics and the protein changes due to BMPR2. The word is mutation. That's an odd word. Many people don't fully understand it. What all it means is that that gene is faulty. And so we'll see, I think, in the next few years, drugs based not on as vasodilators, but drugs that will be remobilizing BMPR2, putting it in the right place and increasing its function. And there are drugs like chloroquine or hydroxychloroquine, anti-malarial drug, and a drug used in rheumatoid arthritis, suddenly recognizing that these may have a role in improving the function of BMPR2, that receptor, and thereby improving patients' lives with pulmonary hypertension. And tacrolimus, a drug I'm very familiar with after transplantation, also has a potential function in improving BMPR2. And there are trials of chloroquine about to start in the UK. There are trials of tacrolimus ongoing in California in the USA. So watch this space. We should be able to be reporting some early results in these areas. Very exciting from the Cambridge group, Nick Morell, who has really now devoting his life to BMPR2, has been able to show in animal models, and you may or may not want to recognize that animal models play a role in drug development. I'm afraid that's going to be how it is. but has been able to show that using this protein BMP9 will enhance in an animal model of pulmonary hypertension that BMPR2 receptor and can reverse pulmonary hypertension. Now, caution here, because the animal models for pulmonary hypertension are not necessarily telling us all and reflecting all that's going to happen in human pulmonary hypertension. There are differences between the various animal models and humans. We recognize this. And actually, the more we do our drug discovery using human cells, importantly, so again, if there are studies going on, some of you may or may not be down a transplant line. Very important that you're willing, but those of you in clinics, you may know the idiopathic group, we're wanting to take blood from you to identify cells in the blood that will be ultimately repairing cells in the blood vessels of the lung to try and work on them. And it's because of studies like this that have now thrown up a whole new potential treatment. Very early days, because the dose that we need to give for BMP9 obviously will be very critical, and none of those studies have been done. We're a long way away from reaching on the chemist and getting BMP9 down, giving it to patients and having a major benefit. But this is where we're starting from. We have to start somewhere, and you can be sure there'll be continued work down this line to explore this new therapy. Now, I mentioned inflammation in PA. Inflammation, very simple. You know, if you prick yourself in the skin with a thorn and there's a little bit of infection there, it gets red and hot, and you recognize it. You might get a little bit of pus out of it if there's an infection there. But the inflammation that is driving all that pain and swelling and redness is due to a whole collection of cells that are attracted there because of inflammatory proteins. Again, substances in the blood which mediate those changes that you recognize as a painful, swollen, red spot, if you like, on the skin. Well, that also happens in airways, and it also happens in blood vessels. And in pulmonary hypertension, a number of people, but this is data again from Elaine Soon from the Cambridge group, showing that if you look at the level of inflammatory proteins in patients with pulmonary hypertension, there tends to be a greater amount of that in the blood of patients with pulmonary hypertension compared to control subjects who don't have pulmonary hypertension. And that's interesting because it's starting to tell us that there are systemic changes associated with pulmonary hypertension. Maybe when you're feeling fatigued and not too well, your muscles are aching. It's almost like a flu-like situation because these cytokines, these inflammatory mediators, are increased in the body generally and having effects not just on the lung, but on the body in total. Some of you are nodding, may recognize those symptoms. So how about forgetting vasodilatation, but choosing a drug that will block the effect of these cytokines on the body in general, but specifically thinking, what about the potential beneficial effects on the blood vessels in the lung? Well, there is such a drug that blocks IL-6, and you'll all shortly be hearing when you go to your clinical appointments that we in the UK have got together as a collaboration. One of the unique features about healthcare delivery in the UK compared to other countries is a great willingness and camaraderie-ship to get to a common aim. We work together because together we're stronger. And we will be performing a national study of proof of concept that does giving targeted anti-IL-6, this inflammatory protein that floats around in the blood and maybe driving some of the changes in the blood vessels. If we knock out that function, will that bring benefit to and improve, again, quality of life and outcome in patients with pulmonary hypertension? And that will be starting early in the first quarter next year. So there you have. Very important that this is, again, I was talking about partnerships, patients, clinician and physician scientists. Also industry, we've got the National Institute of Health Research and Roche Pharmaceuticals funding this investigator-led study. Now it's where it gets difficult, because basic science is moving on a pace in terms of what the underlying mechanisms that may be equally important in making those changes in the blood vessels and narrowing those blood vessels. There is a protein called FOXO, nothing to do with hunting. They all have these funny names, FOXO, but FOXO, we know the function is not correct in pulmonary hypertension. And there have been talks in the past suggesting that some of the changes that you see, the cells that replicate very quickly in the blood vessels of the lung, almost are similar to patients who have forms of cancer. I'm not saying pulmonary hypertension is cancer. Don't go home thinking that's what I'm saying. But what I'm saying is some of the proliferation, some of the increase in bulk of the cells that cause the narrowing of the blood vessels of the lung are due because those cells are replicating very quickly. And that is similar, but it's totally different from a cancer. But there is a drug that's used in cancer therapy, paclitaxel, that has a specific effect of improving FOXO function. And again, in a mouse model, workers in Gießen in Germany have recently demonstrated that experimental pulmonary hypertension is reversed by this therapy. Now again, there are many drugs that have proven effective in animal models that don't work in man. We have to face that. But this sort of data is going to certainly drive a clinical study in man with a proof of concept of a drug that's used in cancer chemotherapy to treat pulmonary hypertension. And without the research work that has shown the links as why this sort of drug may benefit pulmonary hypertension, we would never have guessed or thought of using a drug like this. But you will see in the next 12 months, or we will see, and then you may read about this drug being used in patients with pulmonary hypertension. And there are other drugs that also are currently in development. Another protein called FGF2. They all have these sort of annotations, and it's hard to keep up with them all. But we know, it's a complex slide, but as I gave you the health warning at the beginning, forget all those graphs, just recognize that there's very good, carefully carried out experimental procedures to demonstrate that this protein, FGF2, contributes to the progression of the disease that you are focused, and we're all focusing on this weekend, pulmonary hypertension. And a drug called apelin regulates FGF2. Anybody here from Glasgow? It's a long way down from Glasgow, I know, and you need a passport almost, and will do soon probably. I think maybe one of the other centers too, the apelin is now gone into man as an acute therapy. So patients have received, during right heart catheterization, an intravenous dose of apelin to see if instant alteration of this FGF2 protein may have an influence on the way in which, or the narrowing, if you like, of the blood vessels in the pulmonary arteries are supplying blood to the lungs, which is, of course, the font of problems in pulmonary hypertension. So there's a whole range of drugs, and this is the era where it doesn't matter whether the drug is a vasodilator or not. We recognize that the combination of vasodilators and drugs that will alter the thickening of the blood vessels in the lung are equally important in striving for us to conquer the pathological changes that take place in the blood vessels of the lung, which lead to the diagnosis of pulmonary hypertension and cause all the symptoms that you're knowing about. Now, Dan is going to talk specifically about stem cell therapy. There's a beautiful book, which many of you I'm sure have read, or a pamphlet from the PHA, which Dan was responsible for, and he's, I'm sure, going to talk in much more detail about stem cell therapy and pulmonary hypertension. I will make just a brief comment that there are two ways that cell therapy in general can be considered as a potential benefit for patients with pulmonary hypertension. One is to repair the damage to the blood vessels that we've been talking about by using drugs. But the other is to remember that the pumping chamber, the right ventricle, is a big problem in patients with pulmonary hypertension. You know, and you've seen from David, that the obstructed small pulmonary artery in the middle there, where the lumen of the blood vessel is narrowed by constriction and thickening of the wall, increases the resistance to blood flow. David gave a physics lesson to us all. Yeah, I love physics, but I went to biology, but physics is important even as a biologist. And of course, what that means is that the pump, if you, as David said, if you squeeze that too long, that hose to squirt your neighbors, in Sheffield, of course, sometimes the hose comes off the pipe, and the drive therefore completely goes. And the equivalent to the hose coming off the tap, I should say, is when the right ventricle starts to fail and no longer can effectively pump blood through the lungs. And that is what's responsible for your symptoms. And that's what's ultimately responsible for the prognosis in pulmonary hypertension. And so rather than simply using cells to restore the function of the blood vessel of the lung, one other option in the future, where we're perhaps a little bit further forward, particularly for the left ventricle, is repairing heart muscle or improving even heart muscle function. And we know that the natural process from heart-lung transplantation or heart transplantation, you can demonstrate if you put a male heart into a female recipient, you can see cells that have to have come from the opposite sex into that heart. So we know that there is, as a natural phenomenon, a healing process that emanates from cells circulating in the body. And this may be a future way in which we would augment and improve right ventricular function so that we can not cure the disease, but at least cure the effects or help towards alleviating the effects of the disease for a symptom viewpoint. So this is all a bit complex, I recognize, and I'm sorry, but there will be a chance, obviously, to chat afterwards at the discussion period. And also, I'm going to be around. There's a problem with my car, so I might be around longer. But I am coming back for the Halloween. I wondered about bringing my Dracula suit, but I'm beginning to think I probably should have done, but never mind. The other thing is pumps, devices. We work also with the industry that are interested in developing new concepts. So Sean Gain and I, not so long ago, went to visit a man in Ireland. Sounds like a funny story, doesn't it? But I mean, it's a bit of a funny story. But this is a guy who's a sort of mechanical genius, and he's been thinking, is there a way of perhaps putting some sort of shock absorber in the ventricle so that acts a bit like a valve in a pressure cooker, where pressure cookers allow you to cook food quickly, but there is a problem if the pressure builds too high. Can we put a shock absorber in the heart that will, and the technology will improve its function? So we're a long way from plugging in a little valve into the heart, but the important thing for you to know is that the inquisitiveness and the drive to improve all the things that are going wrong in pulmonary hypertension is covering a vast, vast area. So how can we sum all this rather diverse number of thoughts together? Scientists and physicians, please be assured, are working hard to find new treatments on your behalf. And I think the encouraging thing is, because in many areas there are no drugs in the pipeline, there are lots of new treatments in the pipeline for patients with pulmonary hypertension. And although cure is certainly not yet possible, I believe we're getting closer. The more we understand about this problem, it must be the closer we get to. And just think about that small group of patients, a subset of patients with cystic fibrosis, whose disease is now virtually sorted and have had the most dramatic improvements. So it is possible. We need to do this as a partnership. We need patients to help us by participating in all the clinical trials that are being undertaken in the UK. And together, I really believe we can make a difference and bring about success. Thank you very much.